episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome everybody again to another episode of our show with another really fascinating guest today, helping to create a better tomorrow on many different fronts. Today we have the honor of being joined by Dr. Helene Gayle, who is the President and Chief Executive Officer of the Chicago Community Trust, which is one of the nation's oldest and largest community foundations. And under her leadership, the trust has adopted a strategic focus on closing the racial and ethnic wealth gaps in the Chicago region. An expert on global development, humanitarian and health issues for almost a decade. Dr. Gayle was president and CEO of CARE, a leading international humanitarian organization, and prior to that, spent 20 years with the United States Centers for Disease Control, working on HIV/AIDS. She also worked at the Bill and Melinda Gates Foundation, directing their program on HIV/AIDS and other global health issues. Dr. Gayle serves on numerous public company and nonprofit boards, including Coca-Cola, Palo Alto Networks, Organon, Brookings Institute, Center for Strategic International Studies, the Federal Reserve Bank of Chicago, Economic Club of Chicago, the list goes on and on. She's also a member of the American Academy of Arts and Sciences, the Council on Foreign Relations, American Public Health Association, National Medical Association, American Academy of Pediatrics, and National Academy of Medicine, including serving as a co-chair on their committee on the equitable allocation of the SARS-CoV-2 vaccine. She's been awarded numerous awards, including the Chicago Mayor's Medal of Honor for her work on COVID relief and recovery in the city, named one of Forbes 100 Most Powerful Women and one of Nonprofit Times Power and Influence Top 50. She's authored numerous articles on global and domestic public health issues, poverty alleviation, gender equality, and social justice. Dr. Gayle earned her bachelor's in psychology from Barnard, her medical degree from here in Philadelphia, University of Pennsylvania, and her master's in public health at Johns Hopkins, and has received numerous honorary degrees and faculty appointments, including both University of Washington and Emory. Dr. Helene Gayle, thanks so much for taking the time out of your schedule to talk to us a little bit today.
It's my pleasure to be with you today, Ira.
It's great seeing you, Helene. I'd love to start off like we typically do by handing you the floor for a couple of minutes just to talk a little bit more about your early background. If you could just tell us a little bit about everything from where you grew up to how you developed these early interests in psychology and pediatrics and in public health. I think that'd be a great way to start things off.
Yeah, well, I grew up in Buffalo, New York. And, I think there are several parts of my early days that I think influenced who I am today. One, I'm the middle child of five highly opinionated, dynamic siblings. So growing up in the middle of those, I always had to fight for making sure my voice was heard. I think as the middle child, I also probably took on a bit of the role of being the bridge builder and the consensus maker. And so, I always say to my siblings, I am who I am because you are who you are. We grew up in a family. My mother was a social worker. My father had a small business, barber and beauty supply store. It was where we all had our first jobs and where we worked until we went off for college. And I think, having that experience of working with the public early on, again, I think gave me some real skills around, how to work with a range of people and, really kind of value the diversity and breadth of people who came through his store. And, my father's store was in the heart of the Black community in Buffalo and really did serve a range of social economic status, but was also seen as kind of a community hub. So really, I think very on was part of what deepened my roots in terms of the community that I most affiliate and link to. I also grew up in a time in the mid 60s to early 70s when we were going through a period of rapid social change. And I do feel like the movements that I saw as a young girl growing up, whether it was the civil rights movements, the women's movements, liberation movements, anti apartheid, all of those things really gave me this sense of what can be done when people band together, and this sense of wanting to be part of something bigger than myself as I saw so much rapid social change. And, it grew up again in a family where uh, making sure that we got a good education was an important part of who all of us are, but also to use that education in a way that could give back. And that was always a big theme in our family. How could we give back? How could we
Mhm.
make a difference? And how could we, particularly make a difference for the community that we belong to? So, I think all of those things had a huge impact on me. I kind of wandered into medicine. I didn't go to school with the idea necessarily of being a doctor, but I started recognizing that, medicine and health were so central to
Mhm.
so many other things, and it was a tangible way in which I could make a contribution. But having really grown up with this idea of wanting to create and contribute to broad social change, as I was doing my studies in medicine, I started getting more exposed to public health.
Mhm.
And as a individual clinician, you take care of individuals, and your patient is an individual. But public health, your patient is often a community, or it
Right.
could be a nation, or it could even be the world. And so I saw public health as a way of using my training in medicine, but in a way that could contribute to broader social change. I often tell the story that going to one of my brother's graduation, the commencement speaker was one of the leaders of the smallpox eradication campaign.
Sure.
And I just remember listening to him speak and thinking about this incredible effort where people working together using the tools of public health wiped off the face of the earth one of the oldest scourges that humankind had experienced. And that gave me, had conceptually started thinking about public health, but that gave me the tangible um, example of how public health can be this tool for creating broad social change. And so that was those are some of the influences that led me in the direction that I went into.
Outstanding. And speaking of obviously broad social change, you are the CEO of the Chicago Community Trust. Here we have an organization that goes back to 1915. I think it's the third largest community foundation in the country now. Over $3 billion of assets. We in Philadelphia have something slightly smaller called the Philadelphia Foundation. Could you take a couple minutes and just walk the audience through exactly the community trust model that may be less familiar with it, especially sort of the international listeners that may be unfamiliar with it as well?
Yeah, so community foundations, I always think of them as this interesting blend of being a philanthropic grant making organization, but at the same time, almost in the way of a nonprofit, also something that works with donors who want to invest in their community. So we both bring in dollars through people who have means and want to invest in making change within their communities, but we also then give out dollars to community partners to really help work on change. We're not an implementer. We are a grant maker,
Yep.
but we really do serve to bring money in and then make sure that money gets to the places that can make the biggest difference.
And one of the grants or funding components that you've been actively involved in, the Chicago Community Trust, together with John D. and Catherine T. MacArthur Foundation, the Metropolitan Planning Council, and the Urban Institute, were involved in funding this cost of segregation report, looking at the major impact of segregation across income in communities, health and longevity, overall economic growth, looking at, if Chicago in general was less segregated, billions of dollars of additional income, much lower homicide rates, a lot more bachelor's degrees. And I'd like to dive into a couple of the components of the report, one which recently in the New York Times used both some of the data, and you are quoted in the article is entitled "Black Lives Are Shorter in Chicago. My Family's History Shows Why," and it talks about this fascinating 30-year life expectancy gap between a predominantly white neighborhood of Streeterville, just a couple miles away, the Black neighborhood of Englewood, and aside from this sort of the shocking 30-year life expectancy gap, the concept that in a neighborhood of the United States, they can have a life expectancy of only 60 years.
Right.
I had to go to the United Nations Human Development Index, and there's only 7 countries in the world with less than a 60-year life expectancy, let alone Chicago neighborhood. Talk a little bit, if you would, about this particular finding of the report and a little bit of what you're learning on this particular front.
Yeah, so I'll back up for a minute and just say, um, we have prioritized as the organization as the trust closing the racial and ethnic wealth gap. And that came after I came on board, and we were organized before more, the way a lot of foundations are. We had a health program, we had an education program, we had an arts and culture program, et cetera. And we had these very distinct programs that were doing a lot of really good work, and providing resources to great partners. But it was hard for us to point to where had we had a defined long-term sustained impact.
Mm-hmm.
And so when I came on, we went through, took a kind of almost a year-long journey. And based on the kind of data that you talked about in the Metropolitan Planning Council report, as well as so many other pieces of data, we came to the conclusion that if we could have an impact on closing the racial and ethnic wealth gap, we could have an impact on so many of the other challenges in Chicago region: the life expectancy gap, the education gap, the occurrence of violence, on and on and on. And so, there's so much evidence that shows that this unequal economic opportunity is really kind of a root cause for so many of the challenges that we face.
Sure.
And, a lot of people would have expected that me as a health person would come in and say, let's, focus on a particular health issue. When I came on board, violence had increased, particularly youth violence had increased pretty rapidly, and we could have taken that one issue. But we thought that if we could have an impact on this wealth gap, we could have a bigger impact across the board. The life expectancy gap, is one that, of course, as given my background, I care a lot about. But we also realize that if you look at what really contributes the most to health outcomes, 20% of it has to do with clinical and medical care. The 80% has to do with either behavioral or what we call social determinants of health, which
Sure.
accounts for somewhere between 50 to 60% of what determines one's outcome. So even if you look at something like the health gap, we recognize that if we looked at issues focused on economic opportunity, we would also have a greater impact on health outcomes than if we focused on the health system per se.
Yep.
And so these, what we've now come to call social or social economic determinants of health, whether you have access to nutritious food, whether you have a decent income, good housing, safety, access to transportation, um, safe drinking water, a safe environment. All of these are the kinds of things that are so linked to economic opportunity that also then link to health and health outcomes. And so that's why we decided to have this focus on closing the racial and ethnic wealth gap, helping to grow household wealth, helping to invest in neighborhoods that are disinvested, and then amplifying the voices of residents at the community level.
And it's as you talk about the social determinants, and this is a theme that we've been hearing more and more about on the show from different angles. Obviously, another very important topic next to life expectancy in general, which comes up in the report, but also that you've written about independently. You have this a recent editorial in the American Journal of Bioethics entitled "Race, Racism, and Structural Injustice: Equitable Allocation of Distribution of Vaccine for COVID-19." And once again, you go into the very important data: Black people 80% more likely to become infected, more serious infections, 4 times more likely to require hospitalization and die. And then obviously there's a lot of issues in terms of here we also, in the same group, we have the essential workers living in crowded conditions, comorbidities, once again, social determinants feeding into a lot of this. Talk a little bit, if you would, about this particular paper and some of your findings here. And then, as mentioned in the intro, you co-chair the Committee on Equitable Allocations at the National Academies. Talk a little bit about the framework that you put together there over the last year, because I think this is also extremely important with how what we see and how the benefits of how the rollout has occurred ultimately for some of these vaccines in these disadvantaged neighborhoods.
Yeah, so let me start by just talking a bit about the framework, because I think it was kind of the basis that led to the piece, the article that you mentioned, and some of the other work. So the National Academies of Medicine, Science, and Engineering were asked by CDC and NIH to develop a framework to look at equitable allocation of vaccine, and this was done back in the summer before we even knew if there was going to be a vaccine. We assumed there would be a vaccine available, but there had not been one yet approved for use. And there was a real desire to make sure that we put together a framework where equity was at the core of it. Because of all the things that you mentioned, we knew that COVID had disproportionately impacted communities of color, particularly African American, Latinx, and Native American, and for those social determinant reasons, primarily the places that people lived, the jobs people worked, all of the inability to necessarily social distance or stay at home and work from home, and all the things that put people at greatest risk. And then particularly for a Black population that had so many comorbidities, the death rate was higher because people had diseases that put them at greater risk for bad outcomes. And so throughout our framework, we kept equity at the core of it. And we came out with a framework that looked at what were the main risks, which then correlated with why people got the disease or why people were more likely to get the disease. And then also, where did people live, and did people live in geographies that were high on CDC's social vulnerability index? Again, kind of the social determinants of health issues. And so throughout, we embedded those issues of who's at greatest risk, both because of their geography or because of other workplace comorbidity issues, as well as obviously we knew that older people were also being impacted disproportionately. And pulling all of that together, we came up with a framework that we thought was very much based on equity. Now, a lot of people asked us, since people of color are at greatest risk, why not just develop a framework that says people of color get the vaccine first? Well, first of all, it's not one's biologic status per se, it's sociologic status. And if you said, because you're Black, you get the vaccine first, well, that doesn't make the distinction that I, as an African American woman who got to work from home, was not at risk just because I happened to be African American. And so we wanted to make sure that it really highlighted the reasons why people were at risk and the fact that it's racism, not one's race, that puts them at risk. And then, also keeping in mind that for communities that have had historic mistrust of government, medical research, et cetera, if you were to say, go to the front of the line, all Black and brown people, for a vaccine that was new, um, that, people had a lot of skepticism about, I think it would have had the opposite effect. And I think people would have been concerned once again. We're getting shoved out there first. We're the guinea pigs. They're trying this out on us. And I think it would have led to even more vaccine hesitancy than we see now. So, we tried to develop a framework that really looked at the factors that put one at risk, keeping in mind the importance of having equity at the center of it. And, as I've often said, it wasn't just the fair thing to do, it was also the right public health thing to do. You always go where the disease is greatest.
Right.
And so by having a framework that really focused on the populations where the disease was and the infection was occurring the most, you also were more likely to kind of more rapidly help to bring down transmission and disease because you're going where the disease is greatest.
There was actually a group here in Philadelphia. It was called the Black Doctors COVID Consortium, and I think they must have used a copy of the framework, because it seems like throughout the city they set up a variety of locations, and obviously this issue of vaccine hesitancy was among the other factors, was extremely next to the social vulnerability issues, but the hesitancy issue was also a major thing on their list to address as well. So
Yeah.
nice to see.
Yeah, no, and I think we continue to see and have concerns about populations that are at great risk,
Yeah.
who also still have lack of confidence in the vaccine. But we're starting to see, obviously, that as more people see people that they know and people who they trust getting the
Yep.
vaccine, that's starting to erode some of the lack of confidence.
Mm-hmm. Helene, on the community trust website, it lists a variety of the sort of the solutions that you're involved in, and obviously a lot going on. You've brought together various government organizations, different businesses. You mentioned there's a JP Morgan Chase investment in Chicago that you've been involved with, the City of Chicago Neighborhood Opportunity Fund, and then there's some other sort of core sort of issues that you're focusing on in terms of earned income tax, in terms of housing vouchers, eliminating pretrial detentions, and so forth. Obviously, a lot of solutions here. If you could just take a few minutes and sort of walk through some of the more important, I say all important, but to you, sort of what are some of the core ones that you are choosing to focus on in your strategic plan to sort of move the needle on some of these more broad issues.
Yeah, so think about it in a couple ways. One, we are a grant making organization, and so we either by ourselves or in consortium, as you mentioned, with other organizations, JP Morgan Trust just being one of them, we are able to make grants to partners for specific solutions. And I'll talk about that in a minute. The other part of what we do, and it relates to what you were saying about the earned income tax credit, is to focus on policy. So we have both grant making, but we also believe that policy and public policy levers are incredibly important. And, in many ways, we are as a society, how we are with some of the inequities because of bad public policy. So, things like redlining and other things that, led to some of the ways in which communities were segregated and where some of the lack of economic opportunity came in. And so we really do believe strongly that we need to think about how do we advocate for policies that can help to equalize economic opportunity as well. In our overall grant making and our overall strategy, as I mentioned, our overarching goal is to close the racial and ethnic wealth gap in Chicago. As you mentioned from the Metropolitan Planning Council, it was very obvious from the data that we as a region are losing because of inequity. And so, you can't have 2/3 of your population, which we are 2/3 Black and Latinx, hold the economic potential from 2/3 of your population and expect that you're going to have growth in your region. And we know that um, the annual economic increase in Chicago is one of the slowest of the large metropolitan areas, and we think that that is at least in large part because of this inequity and because it impacts so much of the region's population. So strong imperative for doing that, and we've kind of looked at this in three buckets. One, how do we help to increase household wealth? And doing that through increasing access to good incomes, jobs,
Mm-hmm.
and careers by looking at ways of increasing assets through home ownership, small business development. The small business development program is the one that we work with JP Morgan Chase on.
Mm-hmm.
And then also by reducing debt, because we know that, whether it's student debt, whether it's fines and fees, whether it's predatory lenders, payday lenders, et cetera,
Yep.
that families who may have an income, may even have assets, oftentimes it is winnowed away because of increasing debt. So we want to look at both the asset side, but also making sure that households don't face disproportionate burden of debt. Then the second pillar is how to increase investment in disinvested neighborhoods. We have neighborhoods in Chicago that for decades and decades there has been little or no private investment in those neighborhoods. And without that sort of overall bringing up the economic vitality in neighborhoods, you know, you're not going to, even if you increase household wealth, you have to be living in neighborhoods where there's also economic vitality and where people have access to what they need to have a good quality of living. And then the third pillar is how do we invest in community and community voice so that community is at the table, community voices are amplified, um, and we work a lot with community organizers and others to really look at how do we um, at the at kind of the resident level amplify voice and make sure that what the needs of residents are being met as we think about a holistic approach to it. So those are kind of the three buckets at the household, the neighborhood, and the community level. And within those, that's where some of the grant making that you looked at and some of the specific projects, are where we're making grants. And on the policy side, we're looking at policies like
Mm-hmm.
expansion of the earned income tax credit, um, you know, caps on predatory lending, um, child savings accounts, other things like those that we know are important for stabilizing financial outcomes.
Outstanding. Um, Helene, you obviously between your time spent at CARE at the Gates Foundation, also of course the CDC, you've prior to COVID, you've been involved in many of the other major pandemics of our time. You've experienced an HIV, tuberculosis. You co-chaired with William Fagey of smallpox fame on the NAM committee. Based on the last year of with this extremely rapid emergency vaccine development and what we saw about the potential to speed things up in one area in terms of SARS-CoV-2, as a clinician that has been involved in these pandemics and these scourges, any interesting insight, things that you think or you would hope that potentially could be I mean, I did a show on tuberculosis a couple months ago. 1.6 million dead every year, obviously extremely poor countries. The vaccine we're working with is from 1921. Any other thoughts when you think to your work on HIV to TB, other areas that you've worked in the past, of how some of this knowledge can be translated to these other scourges?
Well, there are obviously real specific things that we've learned from each, but I guess from a broader perspective, I think the fact that we don't invest in population health and prevention means that we're always kind of falling short when these crises occur. And we spend more on healthcare than any nation in the world, and our outcomes are, not at the bottom, but nowhere near where they should be, given how much we spend. And it's because we spend on, um, we spend disproportionately on high tech, uh, hospital based care. Nothing wrong with that. It is exciting to see the advances in healthcare that, we've been able to produce. But again, if you think about healthcare contributes to 20% of our health outcome, our spending is lopsided. If we spent more on population health, more on, making sure that we have a strong public health infrastructure, and if we had some of the other social safety nets that are also important, so that we know that people have adequate food, um, so that we know that people have access to the social services that they need, et cetera, we would have a much healthier population. And we would not be caught flat footed if we, when crises go, cut the CDC budget, and then, when we need the CDC, or, the equivalent health, uh, state health departments, et cetera, when we need them, we have weakened. We've decreased the workforce. We've decreased laboratory support. We've decreased, the ability to have, surveillance systems. We've decreased focus on diagnostic testing that could be important. So, we've got to make sure that we're investing for the things that we know will give us the best overall health outcomes. And as the richest, still the richest nation in the world, we don't have to sacrifice. We can continue to do cutting edge, um, you know, sophisticated, medicine, and we should continue. I mean, the breakthroughs in science and technology are stupendous, tremendous, exciting.
Yeah.
But we don't need to do that on the backs of shortchanging population health and prevention.
hmm hmm Um, thinking about the social determinants again, one very interesting topic that's come up on past episodes is sort of this intergenerationality issue, and one of these isms that we don't hear as much about, or maybe we do more nowadays, and that's ageism, which sort of cuts across many of these communities. And the elderly have so much to teach the young generation, and vice versa. A very important social determinant on many fronts. I don't know. I mean, yes, you've been involved in many different programs at the Chicago Community Trust, but any specific things that are trends you're seeing in terms of ageism, whether they're in the Black or Latinx communities, that any specific things you're doing on that particular front that you might want to mention?
Well, we aren't, specifically, but I would say, I've been very heartened to see AARP, for instance, really step up recently and develop campaigns around health and the elderly. And, I think, one of the things that has troubled me most, and, I'm a pediatrician, so I'm on the other end of the spectrum.
Sure.
um, but, what's really troubled me is I've seen what isolation does,
Yeah.
for the elderly, and particularly during this COVID time. And story after story of parents who went downhill during this time, because isolation is bad for all of us, but it's often, debilitating for an older person who may not have, um, the connections with the world, and when other than perhaps their immediate family, and when you can't see your family, and you can't hug your children, and you can't be, get out to the things that give you pleasure. So, this whole issue of isolation, and there's a lot of science now on loneliness,
Yeah.
and how loneliness has an actual physiologic impact on people. I think it's part of reason why, pets have been so important during this pandemic. So, that if I were to say one thing, that I really have gotten very concerned about, is this whole issue of isolation and loneliness, and what it does, particularly to, an older person.
Yeah, we had I think it was Trent Stamp from the Eisner Foundation talking about the recent study of it's like equivalent to smoking. I forget how many
Yes,
packs of
exactly,
cigarettes, but
exactly.
it's crazy. It's a crazy trend, and we've learned. Unfortunately, we've had to learn through this crisis more about it, but hopefully we can do more as well to address that as
Yeah.
once again an important social determinant. Um, not to bring up a controversial topic, but I'd love if Helene, you could talk just a couple minutes about your recent perspective piece in the New England Journal of Medicine, "Time to Reevaluate U.S. Mifepristone Restrictions." Can you obviously take us just a couple minutes through sort of where we are, both policy-wise, clinician-wise, on this topic in 2021?
Yeah, and that was part of a National Academy of Medicine panel that I was on. That was
Yep,
several years ago, and so I may not be as up to date
that's okay.
as I was when I was immersed in it at that time. But I guess I would just say, I think broadly speaking, we are still as a nation tied up in knots around conception, um, pregnancy, and how we think about a woman's right to choose.
Yep,
And as we know right now, there are different pieces of legislation at different points in different cities that are in different states that are posing a real challenge to a woman's right to choose.
mm-hmm.
And whether it is through a medical abortion or whether it is surgical. I, I wish that there was a way that we could have a dialogue around this that really thinks about how we as a caring society extend that notion of care and respect and dignity to everyone, which to me means it includes
Yep,
an ability for me to make a choice about what's right for me, what's right for my situation and right for my circumstances, and be able to have that discussion that then allows for a range of options
yep,
for a woman and her family to make choices about conception and childbirth.
absolutely. Um, Helene, there is a page on the National Academy of Medicine where Dr. Helene Gayle is quoted. Once you get a movement started, it's hard to turn back. And I think this is a wonderful quote. And a lot of the guests that I interview on this show, they really wish they could start a movement, depending on what they're involved in. And a lot of movements are hard to get started in certain areas. I've done a lot of shows in rare disease, and it's difficult to get a movement started on a disease that affects 10,000 people versus Alzheimer's or cancer, whatever. Um, just based on your, obviously you've done so much, whether at the trust, the Gates Foundation, CDC, and so forth. Any tips, any findings throughout your amazing career on what it takes in some of these areas to actually get a movement started?
Well, I think about maybe HIV as the one that I was most involved with, that I really do think started a movement, if you will. And when I first started at CDC and then moved into work at HIV, it was mid '80s, late '80s, and HIV was still um, not well understood and not well accepted. And I think one of the things that made the biggest difference in our response to HIV was having people who were themselves infected and affected by HIV become the drivers of the movement. And I think anytime you have the voices of the people who are, at greatest risk, have the most to lose, um, it impacts their life the most, and have them in the front, I
Mhm.
think that's when you create a legitimate movement. And every time I've seen people try to speak for a cause, but it's not something that is integral to their life,
Mm.
you know, it, it's a hobby, it's a sideline. But when this is your life on the line, I think you act with a certain sort of urgency that is different. And I also think you bring people along in a different way because they're listening to people who are authentically impacted, who are raising their voice. And so, I always say a movement is best if you let the people whose issue it is lead, and you do whatever you can to support them in that and get out of their way when it's time for you to get out of their way.
Excellent. Helene, any other initiatives, any different conferences you're going to be presenting at, anything major coming up that else you want to talk about? Obviously, there's so much going on, but please take the floor if there's other things that are going to be happening that we need to know about in terms of CCT.
Well, I guess the only thing I would wrap up with is a big initiative that we've just launched, which we're calling We Rise Together, which is really focusing on how we come out of this economic crisis with a lens towards equity. We know that communities of color not only were most impacted from a health perspective, but also from an economic perspective. People lost jobs, um, were struggling for core housing and food, et cetera. And those same communities that were most hard hit by the disease are uh, were most hard hit economically, and were also the ones that were most fragile economically going into this. So we want to make sure that as our economy rebounds, and it's rebounding much more rapidly than we would have thought, given where we were even a year ago. But we also know that that rebound has not been equal.
Mm-hmm.
We've seen the stock markets off the
Yeah.
chain, and people who had money to invest have made money hand over fist. So
Right.
maybe that's a slight exaggeration, but people have done really well, who were already doing well during this pandemic. And so, we want to make sure that as we come out and as we recover and as we bounce back, that the communities that were most impacted are not further left behind. If you look at the recession of 2008, 2009, communities of color never came back to where they were
Mm.
before the recession. So we have committed to working with other partners within the philanthropic community, the business community, nonprofit partners, the public sector, to all band together and really think about what is it going to look like here in Chicago to have a recovery that has equity at the center, just like the vaccine response that also hopefully had equity at the center.
Excellent. Really very inspiring stuff, Helene. I really wishing you the best with this. It's a tremendous set of programs that you have, and for everybody that's going to be listening to this particular episode on the podcast or watching on the YouTube channel, you've been listening to Dr. Helene Gayle, President and Chief Executive Officer of the Chicago Community Trust, leading their strategic initiatives, closing the racial and ethnic wealth gap in the Chicago region. Helene, it was. I just want to thank you again for taking the time out of your schedule to do this. Thank you for everything you're doing there at the Trust. And as we say on our show, thank you for helping to create a better tomorrow through your initiatives. Very, very inspiring.
Thank you, Ira. Pleasure to be with you today.